This year, we are celebrating the 10th anniversary of our annual faculty development offering, Don Wasylenki Education Day. Our goal of the day is to honor and support the development of our teachers and educators, both residents and faculty in our department. The pandemic has isolated so many of us. Now more than ever, Don Wasylenki Education Day provides a space for our faculty and residents to come together and celebrate our collective work as teachers and educators and to advance our field. Our theme for this year is an important one. How do we support safe and equitable teaching and clinical spaces for the patients we serve and the learners we teach? Our program today will begin with Dr. Allison Crawford, our plenary speaker, who will be talking about virtual by design from 9 until 10:30. This will be followed by a 10-minute break for you to grab a coffee and stretch your legs. We will come back together at 10:30 for our poster session showcasing education scholarship taking place in our department. A poster award ceremony will take place from 11:40 to 11:45, and there will be another break from 11:45 to 12. We will then move to our workshops, 3 workshops that will run concurrently and reflect the theme of our day. A big thank you goes out to all those that contributed to the planning, delivery, and coordination behind the scenes for today's event. We have had to pivot to provide a virtual offering of Don Wasylenki Education Day due to the pandemic with a record number of participants this year. So I'm very grateful to our team made up of almost 35 contributors. Thank you to my co-chair, Lindsay Baker, to all our presenters, Susan Lee for her lovely promotional video, our poster moderators and judges, our plenary facilitators, our planning committee, Paula, our amazing admin support, and Discovery Commons for their technological support. This day would not have come together without your tireless efforts, dedication, and valuable contributions. And before I close, please save the date for our 11th annual Don Wasylenki Education Day, which will be offered on Thursday, February 10th, 2022. We hope to see you there next year. So at this point, I would like to introduce Dr. Benoit Mulsant, the Labatt Family Chair of our Department of Psychiatry, to give a few remarks.
So thank you, Dr. Darani. Good morning, everyone. I'm pleased to welcome you to the 10th annual Don Wasylenki Education Day with the Department of Psychiatry Research Day and MindFest, all our faculty, staff, and trainees to discuss teaching, education, to develop new skills, and to share work in progress. During the past year, the pandemic has changed how we deliver training and clinical care. We have worked hard to take advantage of this change and improve our process while providing safe and equitable virtual training and care. This past year has also brought a renewed focus on racial prejudice that exists in our society. As care provider, we have a duty to understand the impact discrimination has on the mental health and the ways prejudice can affect the quality of care. Today's event includes several presentations that will provide us tools to help us to promote inclusion and address prejudice. The Don Wasylenki Education Day also provided an opportunity for faculty and trainees to share their work. As you explore your colleagues' work, I hope you will be inspired to innovate and prepare for tomorrow's challenge. Today, as you heard, is a special day because the department is celebrating the 10th anniversary of the Don Wasylenki Education Day, and I have the pleasure now to introduce Dr. Wasylenki, after whom the day is named. Dr. Wasylenki is a professor emeritus in the department who served as its chair from 2000 to 2010. He was also the psychiatrist in chief at St. Mike's from 1995 until 2010. And prior to that, he served as coordinator of education at the Clark Institute of Psychiatry, a predecessor of CAMH, as the director of postgraduate and continuing education in the department, and as psychiatrist in chief at the Whitby Psychiatric Hospital, now called Ontario Shore. His primary area of academic focus has been the establishment and evaluation of mental health services for individuals with severe mental illness. The inspiration to name today's event after Dr. Wasylenki came from his successor, Dr. Trevor Young, in recognition of Dr. Wasylenki's advocacy for education. Under Dr. Wasylenki's leadership, several innovative and knowledge transfer programs began, including the Toronto-Addis Ababa Partnership, Psychiatry Partnership, and called TAP, and the Clinician Scientist Training Program. At the Faculty of Medicine, he was the founder and course director for the Health, Illness, and the Community undergraduate course, for which he received an Aikins Award and a Northrop Frye Award for educational excellence. Naming our annual Education Day in his honor was a natural choice. Please join me in welcoming Dr. Wasylenki.
Thank you again, Benoit, for that very kind introduction. And I want to say again what an honor it is to have my name associated with Education Day in our great department. Now, what I'm going to do briefly this morning is I'm going to revisit some remarks I made at the first annual Education Day 10 years ago. And my focus is going to be on what we can learn about education by studying the careers of three of our most outstanding educators. First, Ivan Silver. He is a world leader in continuing education and a champion of lifelong learning. He has just completed his term as Vice President of Education at CAMH, and he's a full professor in our department. Ivan began his career by developing innovative approaches to teaching geriatric psychiatry, making it fun. Soon he rose to Director of Continuing Education, and he revolutionized the field. And his secret was to make everything much more interactive and to really engage teachers and learners. Ivan was a driving force behind the Royal College Maintenance of Certification program, another aspect of his commitment to lifelong learning. But where Ivan really made his mark was as founding director of the Center for Faculty Development. This became a laboratory for his energetic inventiveness, and he applied this to developing a whole series of contexts for interprofessional learning, bringing together surgeons, family physicians, internists, psychiatrists, and others together for faculty development. This is a very substantial legacy. Ivan next went on to become Vice Dean of Continuing Education, and in her tribute to Ivan's completion of his term, Dean Whiteside acknowledged the tremendous impact he had on all of the deans through his participation at the executive level of the Faculty of Medicine. Next is Brian Hodges. Brian was told early on in his career that education was not a suitable area in which to invest time and energy. Fortunately, he didn't listen. Currently, he is Executive Vice President at the University Health Network and a full professor in our department. Early on, as Director of Undergraduate Education, Brian applied his considerable intelligence to issues of assessment and measurement. This led to his championing of the OSCE examination, an assessment tool to which Brian's name is now attached around the world. He went on to become Vice Chair Education and to found the RISE program, which provided a home for clinician teachers and clinician educators in a very exciting educational environment. From RISE, Brian went on to become Director of the Wilson Center. Brian used this opportunity to assemble an impressive array of scholars with a focus on interprofessional learning, and he himself became a world resource, traveling around the globe to advocate for progressive, interprofessional, evidence-based approaches to teaching and learning. In addition to his scholarly contributions, Brian led two highly successful knowledge transfer initiatives. He was the founding director of the Ontario Psychiatric Outreach Program and was a leader, along with Claire Payne and others, in developing the Toronto-Addis Ababa Psychiatry Project. Both of these programs are splendid examples of educational innovation, organization, social responsibility, and partnership building. Next, Susan Leaf. Susan was our Vice Chair Education. She was also Director of Academic Leadership Development and founding Director of the Education Scholars Program, both at the Center for Faculty Development. And she chaired the Royal College Geriatric Examination Development Committee and is a full professor in our department. Like Ivan, Susan started out in geriatric psychiatry and rapidly established her reputation as a leader in postgraduate and fellowship training in her field. She became the founding chair of the American Association of Geriatric Psychiatry Training and Teaching and Training Committee and led a number of important and exciting developments across North America. From her base in geriatric psychiatry, Susan moved into the field of interprofessional faculty development. As noted, she became the founding director of the extremely successful Education Scholars Program. In this role, she mentored, taught, and inspired a substantial cohort of faculty members from all disciplines, medical and non-medical, in the Faculty of Medicine. Her energy, enthusiasm, and rigor have made the Education Scholars Program one of the great educational success stories at the University of Toronto. Then, as an effective leader herself, she became interested in the study of academic leadership, and she created a fruitful context for this work at the Center for Faculty Development, where she was Director of Academic Leadership Development and founded the new Emerging Academic Leaders Program. Susan has received one of the highest honors available to educators at the University of Toronto, a University of Toronto President's Teaching Award. Well, we can't all be superstars, although some of you here today may well turn out to be, but we could all learn important lessons in reflecting on these three careers. The first thing that characterizes all three is their incredibly positive approach. These are people who see a glass that is 90% empty as half full and who have many ideas about how to fill it to overflowing. And this is a wonderful attribute and a key contributor to success. As you know, there's a burgeoning literature on positive psychology and the impact of positive attitudes on success in life generally, and these three individuals exemplify this attitude. Secondly, all three are innovators. Innovation is what sets apart the true leaders in any field. In order to contribute, it's important to master what is known. In order to move things forward, it is essential to go beyond, to innovate. And in the fields of educational assessment, knowledge transfer, and faculty development, these three have advanced their respective fields. The third attribute is rigor. To be truly successful, it's necessary to harness some of the enthusiasm and creative energy to do the serious work of organizing, communicating, and providing evidence in support of ideas. These three have all been successful grant recipients, presented and published their work in prestigious venues, have achieved international recognition, and are all full professors in the Faculty of Medicine. Until recently, scholarship in education was not recognized as an easy pathway to promotion at the highest level. Fortunately, this is changing. A fourth theme in the work of these three is that it has transcended their own discipline. It has been truly interprofessional. All three have had major impacts outside of our own specialty and have been recognized as leaders by fellow experts in other fields. Initially, as I watched each of them move beyond our department, I worried that we were losing important resources. However, what they have really done is enhance the profile of academic psychiatry by achieving excellence in a broader area and by shaping important agendas across the entire Faculty of Medicine, the university, and beyond. The final attribute is generosity. In a large department such as ours, it is very important that senior accomplished faculty members make themselves available to junior and mid-career colleagues for inspiration, advice, mentorship, and instruction. These three people have been incredibly generous with their time and intelligence, and I'm sure many of you here today have been helped in your own development as faculty members by one or more of Ivan, Brian, or Susan. So this is my message today. a good way to succeed is to study the successful. And the 5 lessons here of positive attitude, innovation, rigor, interprofessionalism, and generosity are exceptionally well illustrated and will serve you well. So thank you very much for listening, and I'll turn things back over to Shaheen.
Thank you, Don, for your remarks, those lovely remarks commemorating the 10th anniversary of our Don Wasylenki Education Day, and for your long-standing dedication and support to teachers and educators in our fine department. And now, for our plenary, I'm honored to introduce to you our speaker, Dr. Allison Crawford, who will be presenting today on Virtual by Design, exploring what learners and supervisors need to know to provide equitable and safe care. Dr. Crawford is a psychiatrist and the Associate Chief of Virtual Mental Health and Outreach at the Center for Addiction and Mental Health, an Associate Professor in the Departments of Psychiatry and Dalai Lama School of Public Health at the University of Toronto. She is the Chief Medical Officer of the Canada Suicide Prevention Service, Medical Director of the Ontario Psychiatric Outreach Program, and a founding co-chair of ECHO Ontario Mental Health, an award-winning virtual community of practice model. These activities advance access to mental health services with a focus on equity and access to quality mental health through virtual care. Please join me in welcoming Dr. Allison Crawford.
Thank you so much, Shaheen. I'm just going to take a moment to pull up my slides. More learning. Okay, well, thank you again. I'm going to be talking about something that's really top of mind for all of us, especially me right in this moment, which is how we manage in this new environment of virtual care. What do learners need to know? Milestones in virtual care do we expect residents to reach over the course of their training? By extension, obviously a lot of us are interested in this because we think about what as faculty do we need to know in order to support that learning. Many thanks to many people are necessary. You'll see Cheryl Pereira's name actually highlighted. I wanted to thank her so much, and a yellow highlight was all I could think of. And many of our team members who participated in this work and in putting this together today, and you're going to meet many of them as facilitators. So you will, we decided not to make you do Zumba, but we will do breakout rooms shortly. I'm going to set up a few things first so that you can have some conversation with colleagues about what your experiences are in virtual care and what you think residents need to know. I want to also acknowledge a new working group in the department. Much of what we co-create together today will be analyzed by this group, and we'll be sending around a resident and faculty handbook in virtual care in the coming weeks. All right, so I'm going to spend most of the time today, and now that we're well into the time, talking about the first point here. What are the competencies that we need to think about in virtual care, both for residents and for ourselves as faculty? What's the literature on those, and what have we learned so far during the pandemic? And part of the rationale for the breakout rooms is doing a bit of crowdsourcing to hear a range of experiences. I know equity and safety are in the foreground for many of us, and so I will speak to those as well. First of all, I wanted to start off just by talking about an experience that I had. So shortly after I took over for the Northern Psychiatric Outreach Program, I was doing a clinic in person. So outreach at that time was largely, we did a little bit of telepsychiatry, but it was largely flying to communities in person. And I was in Sioux Lookout to do an ambulatory clinic. And what would usually happen, there are about 35 First Nations communities surrounding Sioux Lookout. And patients would be flown down to have appointments. And there was one young man that people were very worried about, but he wasn't able to fly down for an appointment. I can't really remember why, but I made the suggestion. Telehealth was pretty new at that time in the health centers, and that we connect over televideo. So that was, as far as I can recall anyway, my first experience doing telehealth, oddly from Sioux Lookout to an even smaller community. But when I met with this fellow, some of the concerns had to do with he'd withdrawn, he had a change in behavior, and people, I was thinking, oh, is this, a prodromal phase? But he made pretty good eye contact. Well, what we take as eye contact over virtual care. And I couldn't really discern much that was challenging. I still had lots of questions though. So I connected with his social worker at the health center after the appointment. And the first thing he said was, so what did you think of his rapping? And I was so blown away because we had not a great connection. And when he was talking in a staccato voice, I understood that as a disconnection in the line, but it was actually part of his thought process, had really changed as a result of this illness. And I had completely missed it because I wasn't anticipating that intersection between doing a clinical assessment and the technological environment. So that really left me, that was today was a disorienting dilemma. That was another disorienting dilemma that really made me think about the way we provide care and set me off on this path of wanting to inquire into, so I'm going to adjust my slides. You can see my notes there. That is a photo, by the way, of Sioux Lookout and Menoyawan Hospital. But it made me ask a lot of questions. What technical needs did I have? How did I adapt my evidence base to meet this young man's needs? What did it mean to provide recommendations that would make sense within his community? Could I provide a culturally safe experience for him as a First Nations young man? And really, most importantly, what was the system of care that I was participating in, and how did we start to think about organizing virtual care under these conditions? A couple of very quick definitions. So when we say digital health, we mean that larger umbrella of really any technology integrated into healthcare, including wearables and apps and so on. Virtual care tends to be used to mean a clinical connection, whether it's directly with a patient or other people in their circle of care, sometimes used interchangeably with telemental health. So I probably use both terms, and a paper that I'm going to tell you about, we use the term telepsychiatry. So lots of different terms, but I think we're all used to these shifting terms at this moment in time. So the need to access mental health care, especially with our dispersed geography, with workforce, uneven workforce across that geography, patient demand, and now COVID-19 are all forces that are driving the expansion of virtual care. In healthcare in general, I think we've been very slow to adopt these technologies. If we think about it, this is really video conferencing that we're talking about. We're kind of many years behind. And in Canada, have been even relatively slower. So for example, in the UK in 2017, about 14% of their primary care visits, 14% of about 20 plus million visits were done by virtual care. In the US, Kaiser Permanente does millions of, they call them touch points virtually. In Canada, up until about a year ago, we provided less than 1% of psychiatric care through televideo. And one study that we did, led by Eva Surhall, really showed this less than 1% and also a very disorganized system of providing that care. One LHIN providing to another LHIN, providing to another LHIN, and a lot of equity issues baked into the system design. The same was true, I think, at the hospital level. So at CAMH, prior to the pandemic, we were also doing about 1% of our visits by virtual care. Oh, and now you're not going to see the slide. Okay, I was going to show you the real graph. We went from 350 consults per month in December 2019 to about 9,000 consults per month or virtual visits per month over the course of the pandemic. And I feel like this slide really shows a curve that we're all familiar with from 2020. Everything went up, and it went up in a big way. With this accelerated use of virtual care, and everyone talks about how we pivoted, we maintained access to a lot of important services. But however, there is a cultural shift here as well, and it's really not complete, and a health system shift. There are a lot of gaps that we still have to understand. So there are a lack of guidelines and standards. I'm really excited to be working with the Canadian Psychiatric Association to develop Canadian guidelines for psychiatry in virtual care. There are new configurations of clinical work and supervision, which we'll talk about. This lack of integration that I've mentioned, and not necessarily attention to quality of virtual care and safety, including cultural safety and the safety of our trainees and our providers within the virtual care environment. There's also been a real lack of involvement of people with lived experience in the design of these services. So those are some of the limitations, but they also present a lot of opportunities at this juncture. One of the big learnings during the course of the pandemic is about health equity and some of the barriers to accessing virtual care that some of our populations and individuals experienced. You definitely won't be able to see this diagram in this view, but Eva Serhol and I have developed a framework to really look at that flow between structural issues that people face, social and structural issues that contribute to social determinants of health, and in turn, as you can anticipate, impact digital determinants of health, and really that we have to address in order to achieve equity in this field. So not only do we have this increased use of televideo, we have, and that really propels us to think about education in this area, but some of these gaps, which our profession, we need to be leaders in addressing these gaps. And I think that charges us even more with the importance of thinking about virtual education for ourselves and for residents. Right now, understandably, there's a lack of consistency across sites. I don't know that we've really thought systematically about the impact of virtual care on resident wellness and some of the things that go with that. So increased isolation and independence, maybe at an earlier point in residency. We have had a curriculum in telepsychiatry training, but since the teaching has been reorganized, that formal block in the core curriculum has been lost. And so I think we have to think about where we insert this training. And interestingly, at a sort of the Royal College level or the competence by design level, there are no EPAs in virtual care. I don't know about in other specialties, but definitely not at this point in psychiatry. Right now, most most residents who access virtual care teaching do so through selectives in the first and third year, the marginalized population selective. And they also have the opportunity in PGY5 to do integrated care through virtual care. We just completed a survey on resident learning needs. It's 103 residents filled it out, and about 8% of people hadn't used virtual care at all, including in education or teaching. But what you see in this graph here is the 4 different ways people might use virtual care, and the dark blue bars at the top, all the colored bars from the bottom up go PGY1 all the way up to PGY5, but the dark blue bars are people who have not had experience using virtual care in that realm. So providing psychotherapy, the vast majority of respondents had not used virtual care for providing psychotherapy or receiving supervision. And approximately 70% of those who responded said that they would like training and education in all of these areas, providing clinical care, providing psychotherapy, which really is part of our full scope of practice, receiving supervision, and for education. Here, this question was about how prepared they felt. And you'll see that a significant number felt prepared, but a lot also felt less than enthusiastic in their degree of preparation to provide virtual care. That's the middle bar. And this is a little bit humbling for all of us. Most agreed that their supervisors could use more training or experience in virtual care in order to supervise those events, those learning events. And these, I won't show all of these, but we also asked them within each CanMed's domain, their level of confidence or their self-efficacy in providing virtual care through that lens or through that CanMed's domain. This is the medical expert role. And you'll see that, and this was true across all of them, most of them filled out about a 50%. They felt 50% confident, confident in their abilities to provide care in that domain. Other areas where confidence, and you see the blue, the lighter, I guess medium blue, towards the left, indicating less confidence. Those are PGY1 respondents. Other areas providing culturally safe and trauma-informed care, being a health advocate, and being a scholar in virtual care were all relatively low in terms of resident confidence in those areas. So if we recognize the need for these training experiences, I think there are lots of questions that we have to address. Time for many more Donald Wasylenki days and other training events. But when do we expose residents to virtual care teaching? What do they need to know? How do we supervise this? How do we evaluate it? And again, thinking about resident wellness in this context, as well as other contexts, are all open questions. And I think we'll really benefit from using an established model to develop this teaching. This is Kern's model, 6-step model. And right now we really are still at that kind of needs assessment phase, which I think the resident survey shows. But that doesn't mean we stop teaching. We're all teaching in this area right now. But over time, as we develop new pedagogical models and methods, so right now we're working on some simulation, for example, and as we get evaluation and feedback from residents and from faculty, I think it's an area that we'll all keep developing. All right, so now I'm going to share what we do know about competencies, and I'm hoping to get us into our breakout rooms in a moment. So I'll go over this relatively quickly. But this is a paper we completed in 2017, feels very old school now, with Nadia Sunderji and Sophie Soclaritis. We did qualitative interviews at that time of faculty and residents and their experiences of being supervised or teaching or providing clinical care through telepsychiatry. And we've since applied that to other domains such as integrated care, and we work with colleagues in the US to share our knowledge around competencies and publish on our shared learning. So one of the things that we found when we interviewed, especially faculty actually, was a little bit surprising that at that time faculty tended to minimize the skills that they had developed and the knowledge and expertise they had gained in providing virtual care, and had a hard time articulating what it was that they thought residents needed to know. And I think, and many of them, because they had streamlined it into their practice at that time, they were the sort of early adopters. They just thought, well, it's the same old, you just turn on the computer and away you go. So what we started to do, we were getting very kind of flat interviews and starting to think, why were we doing this study? But what we did, we started to use a kind of talk aloud methodology, and you can see it here on the screen. Hopefully you can read it, but inviting people, and I'll invite you to do the same thing right now before we go into the breakout rooms. Think of a time you were providing or supervising telepsychiatry or virtual care where you found yourself unsure of what to do or out of your comfort zone. What do you wish you had known? What skills do you wish you had had? What did you learn from that situation? And what could others learn? So keep a mental note of that before we go into the rooms. What we found when we analyzed the results of the study was that then what people talked about really mapped on very well to the CanMEDS domains. That really, we bring all of the aspects of our professional selves into providing virtual care. And we reviewed this with the Royal College and got permission to use the CanMEDS framework to disseminate these results. And that's what we hope to continue to refine and use what we're learning now as part of the pandemic to really flesh out and keep relevant these competencies. I'm not going to, you don't need to read that right now. And in fact, we're going to disseminate, this will be in the resident handbook, updated based on what we talk about today. And I just wanted to say a couple of words. I haven't spent much time. This is Donald Wasylenki Day. Everyone amazing, like education scholars and theorists who often present during this day, talk about learning methods. I haven't spent too much time on that, but I did want to mention transformative learning. There are other, I talked earlier in the resident survey about self-efficacy, Bandura, which relates to Bandura's work. Sanjeev Sokolingam, I can't see anyone on the screen, but I know he's there, has really sold me through ECHO on the idea, the importance and the idea of adaptive expertise, which I think is very applicable here. So adaptive expertise is that kind of learning as a productive struggle that is scaffolded and supported as part of learning so that we can apply our knowledge into increasingly complex situations. I think that very much applies to what people are learning in virtual care right now. But the theory that really resonates for me at this moment is transformative learning. You've heard me mention a couple of times disorienting dilemmas. So in transformative learning, we take those disorienting experiences that really cause us to reflect critically and understand what we're doing and question what we're doing. It's a process of continuous reflection, critique, and reevaluation of what we know. And I think we're still in this this zone of uncertainty when it comes to virtual care that makes this learning theory very productive. And I think can also be very productive in teaching, that kind of humility and transparency about where we're at and having a dialogue about, so for example, in my initial example, what did this mean that I made this technical slip and how could it be prevented in the future? What do we know about that? Going to the evidence, that really reflective kind of practice, I think right now is very timely. Nope. Okay, I think that process of questioning, I'm just going to go through some questions that might have already occurred to you in your virtual care. So is CBT for depression delivered via televideo a first-line treatment for depression? Answer is not according to CanMat, second line. I think that will change. My patient has a history of online bullying. Are there ways to be trauma-informed in virtual care? So really the medical expert role in virtual care. My patient is not very talkative online. How do I establish a therapeutic alliance? So being a communicator in virtual care. I work with a whole primary care team. They keep making the same referrals. How can I introduce a collaborative care model using virtual care? Being a collaborator in virtual care. You're not getting to see my animations. These little things are supposed to come popping out. It's okay. I have 3,000 patients in an underserved location. How can I use virtual care to meet these needs? Being a leader in virtual care. And how can I provide psychotherapy to my patient who's underhoused or ensure privacy for my patient who lives in a bachelor apartment with an abusive spouse? Being a health advocate in virtual care. Is my practice that is now 70% virtual care saving the health system money? So one of the questions in terms of economic analysis or quality improvement that we might ask as a scholar in virtual care. And what do I do if a patient records a virtual group session without the group's permission being a professional in virtual care. So ethical dilemmas, boundaries, those kinds of issues are questions that come up. So hopefully that invitation for you to think about an experience you've had of a kind of disorienting dilemma in virtual care, some of these questions, we'll harness those as we go into our groups. I'm going to skip this just to say the Royal College has actually in 2020 introduced a number of competencies in eHealth, and if you've ever used the interactive CanMeds portal, it's actually pretty cool, and you can filter by hot topics, and one of those hot topics is eHealth. I think they're still pretty high level, and I think in psychiatry we need a bit more specific guidance, but well worth looking at. And just thinking about our colleagues in the US, there are a number of competency frameworks that I think are quite well developed and worth looking at. But these slides are available to you, and you can look at that further. So let me introduce the idea of the breakout rooms. So we're hoping to get you in a situation where you can talk to each other a little more, at least by chat, and we'll use that to contribute to the development of competencies and to the resident handbook. So we're going to go into breakout groups. They're organized by CanMeds domain, but you're just going to randomly be assigned to one. So be open to any CanMeds domain. Each room will have a facilitator to lead a discussion. Thank you so much to the facilitators ahead of time. You have 20 minutes. We're a little, I don't want to say we're behind time. We're in perfect time. 20 minutes in that room to answer a couple of questions. This has been approved by the U of T Research Ethics Board. The rooms will be recorded for the purposes of note-taking, but if that's not comfortable for you, you have a few options. You can change your name on the underneath your picture. You can also turn off your camera when you're in the breakout room, and if you're really uncomfortable, you don't have to participate in this part, and you can join us again in 20 minutes. But we really hope that you will feel comfortable and that you will participate. A reminder, this is going to be a discussion about competencies. So I won't go over all of these, but key competencies we think of as like the roof on the house. It's the overarching, the big thing that has to be achieved. And enabling competencies are the walls of the house, or all the smaller components necessary to hold up that roof. Milestones, don't worry about that right now, but we might get a chance to talk about that later. It's really about how are they mapped out across their residency training. All right, the facilitators have instructions, so I'm actually just going to pass it over to Wally right now, who is going to get us into breakout rooms. Hi, everyone. I think people are back, making their way back. Hopefully that was really fun. That was really fun, everyone in virtual space zooming around. So great. I hope you had good discussions in your group. We, in the meantime, figured out the slides, so you don't have fuzzy slides left. So I thought I would go back to this particular slide. This will be disseminated through the resident and faculty handbook in virtual care and updated based on your discussions today. So everything that you talked about in your groups, we'll be looking at that, looking through examples, revisiting this framework, and we will disseminate that with more teaching tips. I'm just adjusting a little bit here. We were going to have report back, but there are 113 of you and 14 groups, and we started late and had a few technical difficulties. So I think what I'm going to do is just invite you, whoever was the spokesperson for your group, invite you to share in the chat what was really one of the key competencies, or you can put both because they're in the chat. What were the key competencies that you guys discussed in your group? And that will allow people to get a kind of sneak preview, but I promise we will disseminate this. And instead, I'm going to go to, sorry, just one sec, because now I'm flipping ahead. And you get to see the graphics that you missed, or the animation that you missed earlier. I'm just going to flip through here. All right. So some of the ideas that came up, we'll look forward to exchanging those among you. But a couple of tips. So when we think about this, comes from that first paper and also learnings since the pandemic, and I'm sure some of these will have surfaced as themes for you. But I did, even if there's not definitive education yet in virtual care, I think it's very much under development, but wanted to at least give some ideas to take away to consider in your own teaching and practices about the ways that you can attend to all of the different roles in when you're supervising residents or providing virtual care. So as a medical expert, obviously that's the very synthetic role, and it brings together all of the things that we do. But some real core tips are, assessing patients and clients for appropriateness for virtual care, how to conduct an assessment, including thinking through how to do a mental status exam. You'll remember my first example of the, how you look at rate and rhythm of speech would have been a good thing to talk about in that case. Knowing the evidence for interventions delivered through virtual care, and also how to adapt interventions for a virtual environment. And increasingly, there are lots of tips out there. So for example, how do you give homework if you're doing virtual care of CBT through virtual care would be one example. Considering and enhancing patient safety, including cultural safety. So a really concrete example is the one I gave earlier of a client who's experienced online bullying, but there are also other factors that might, you'll remember with trauma-informed care, any situation that we go into, we're thinking about the impacts that our interventions can have, and that includes virtual care. So thinking through how to be culturally safe and trauma-informed. Within the communicator role, some highlights, and very curious to see what you talked about in your groups, but knowing the uses and limitations of technology in communications. So for example, there's some information that we just don't get through virtual care. One of the examples that's often used is if someone is either intoxicated or even has more subtle signs of withdrawal, as an example. There are limitations in the information we have available to us, and often we have to partner with others to augment that communication. How you build rapport or alliance across virtual communications. And privacy is a huge issue. How do we ensure privacy? How do we support clients to create private spaces? So I know that, I know people who are seeing clients in their cars, where the client's in their car, as one example, or in a different location. There are hand signs for people who may be in abusive situations to indicate that to the person on the other end. So that's safety and privacy. Supporting patients' uses of digital technologies, so their digital literacy. I think we're going to see a lot of refinement of this and the introduction of, using peers. This is a perfect way to use peer supports to get people up on digital technologies, and also checking our assumptions. If you think about our initial assumptions that, the elderly won't be able to adapt to this way of care, but actually that hasn't, it's just taken a bit longer. That hasn't proved true. All right, and being a collaborator in virtual care, some things to attend to and to think about what you're doing so that you can teach them, how you work as part of a team across different physical sites using technology, how we share knowledge and information through technology, how we collaborate to ensure that there's appropriate follow-up and transitions. This is definitely a big concern right now. We get access to people and they get access to us, but how do we transition care? If from one provider to another, from a program to another, how do we hand people off to different programs in virtual care? Being a leader in virtual care. So understanding the role and integration of virtual care within the healthcare system and supporting residents to think about those roles that they can take on as change makers, as people who are going to recreate the health system with virtual care in mind. How we take steps to improve the quality of care through virtual care and manage care, virtual care as part of a practice. I don't know about you guys, but I found initially actually it still happens, but all of my appointments just ran together in this big blob, and I was absolutely exhausted at the end of the day. So how we think about a virtual practice and manage that in all ways, and including financially, to think about that. So as a health advocate in virtual care, I think this is a really key area. You know, the attention right now that we're paying to equity makes this even more important, but how we involve people with lived experience in improving access to care. So sometimes when we talk about health equity and vulnerable populations, we tend to think about the limitations of people, but how we draw on the strengths of people to support and foster their experience and ability to access virtual care. And mitigation strategies. So if you are working with an underhoused population, for example, what kinds of strategies can be used to improve the equity of that situation? And I think you can see as I'm like flying through these, and I'm sure you all spoke about many different aspects of virtual care that you've encountered. There are so many, the focus of this talk could have been on so many different things. It's really thinking about all of our roles and skills and all of our knowledge and how it would fit into a virtual environment. I'm going to talk about some resources at the end in case people, if this, you know, something has been highlighted for you that you feel you want to explore more, where you can do that in more depth. And then as a scholar, supporting knowledge of best practices in virtual care, how we assess our own learning needs and support residents to assess their own learning needs within virtual care. I was very struck that actually there was a group of residents who put their confidence at 90 to 100%. I don't think my confidence is at 90 to 100%. So what are the areas that we feel we can continue learning? And adapting our teaching and learning style and assessment for virtual care and supervision. And also, you know, residents do a lot of teaching, helping them and supporting them to adapt their teaching style and assessment for virtual care. And finally, being a professional in virtual care. For me, I think this has been one of the biggest transitions, and thinking about one's professional identity and what it means to have this as such of a big part of our practice. And then, you know, on the individual level of the patient level, how do we set boundaries in virtual care, attend to our own self-care needs, and other ethical dilemmas that might come up would all fit under the professional role. All right, so you can expect more information on this in the coming weeks. I did want to just go back to this idea of transformative learning. And the questions that are up here, we developed as part of our ECHO Coping with COVID. ECHO, as many of you know, is a virtual community of practice. And this particular ECHO was focused on supporting the well-being of providers during the pandemic. And we were very aware back in March when it was started that there was a lot we didn't know as well about the pandemic, about what people's needs were going to be, whether there were going to be any challenges in terms of psychological well-being and supporting patients. So this idea of taking a transformative approach was very important. And these were questions that we developed to facilitate that reflection with our participants on ECHO. I think they're very applicable to work right now with each other and with residents. So if we find ourselves in a disorienting dilemma in virtual care, kind of wondering together, you know, are we in unfamiliar territory? How can we explore this together? How can we go look for the evidence? What can we learn? What do we need to know? So going back to that first situation that I told you about, if I had had mentorship at that point, talking about, yeah, what was going on here? How could we think about the healthcare system? What adaptations could we make to ensure cultural safety for this client? So these are things that we all do, bringing this reflexive and critical stance to our work. And I think I'm at the point of almost finishing off. We may even have some time for questions. But this was something in that reflective vein that I wrote early on in the pandemic. And even having done virtual care for 10 years, I've learned so much, and I continue to learn about virtual care. And all of a sudden finding myself both like a provider, a caregiver to my mother, which I had to do virtually, a patient, having medical appointments, teaching virtually, and then even in other realms, being a kind of teaching assistant to my children. I can actually hear them right now. I'm surprised they haven't come pounding through the door. But really all of these things present these disorienting dilemmas, but that we have lots of other skills to apply in order to facilitate our learning and learning of residents. So a few resources though, if you do want to go further. This is a rather humorous one. You will all have done all of these things already, but the amazing David Goldblum showing us the don'ts, and then I get to do the rather boring do's of telemental health. It's a nice introduction for anyone new to telehealth.
Yeah, so we do have a few minutes. 10:30 is the time that we have to go until Allison. So this might be a nice opportunity for participants to ask questions of Allison. I do see a question earlier on in the chat from Rob Madden. Allison, when you initially were speaking, does virtual care include telephone care?
Rob, actually, I saw that, and that is a fantastic question. It does, because it is a technology, and this gets at the appropriateness of care. We just need to determine, is the assessment that we're going to provide possible over the telephone? And actually, I think the telephone can really enhance equity of care. I know we use the telephone a lot in Nunavut, for example, where video is sometimes less stable. And also balancing, I haven't talked about this yet, but balancing equity of access to care and patient choice. You know, we have lots of patients who don't want to do virtual care, and so telephone offers a way to add another option where appropriate. And you can do a lot. And I think that also goes with, there's a question here, how can we measure patient perception of virtual care? So that is something, if you go to the resources, we have developed a validated tool called the Virtual Client Experiences Survey. And it's a 23-item tool that maps onto quality of care domains. So the patient perception of those different quality domains. So timeliness, effectiveness, efficiency, this is a memory test, safety, and we collect some demographics to look at equity data. So you're welcome there's a link to that on the CAMH website. Welcome to use that widely. It's also available in a fillable PDF and electronically. And that's given us a lot of information. I can say, early on, we knew about these equity issues, but when we measured them, we experienced them across every possible, in every way at CAMH. So gender, age, ethnicity, income, housing, level of housing, there were equity gaps across all, and measuring that has allowed us to start closing those gaps. So although today focused on education, I think patient care, we have to attend to that quality care so that we can do teaching in quality care and show people how to have those skills as they move into their transition to practice.
Allison, there's another question here from John Tashima. What are your thoughts about preparing learners for virtual care, not just for the technology now, but for future technological innovations to have adaptive expertise for virtual care?
Thank you, John. I love that question. And I know Sanju is going to smile. You're using adaptive expertise. I think figuring out not just the competencies, but how to space them and time them across residency training so that we scaffold that complexity. Because you don't want to throw someone in and make them responsible for something where they haven't had that kind of stepped approach to attaining milestones. So that's the first thing. And I do think this is where that transformative thinking and approach can be very helpful to show that we are constantly adapting. This is a lifelong learning. Another one of Sanju's favorite theories. So this is about introducing the idea of technology is not static. We're not going to be using flip phones forever. As it changes, and that's why some of these other domains, like being a professional, thinking through ethics, critical thinking, that's why it's important to cultivate those skills so that it's not just the technical knowledge. Early on, I think that's what people were focused on. You know, what kind of camera should you use? What kind of internet should you have? Those are necessary, but not sufficient. We have to think beyond the technology specifications and help people imagine a professional identity that is always adaptive and flexible and will incorporate the technologies. I feel like there's more pressure socially than from within our profession to make these shifts. And that may have changed during the pandemic.
Allison, there's another question from Jeffrey LeBlanc, one of our residents. You spoke about the disconnectedness of the existing network of psychiatric virtual care. This is particularly evident in Northern Ontario, where much of the virtual care is being provided by Toronto-based providers. How does the system work to move virtual care provision away from a Toronto-centric base to more local and likely more culturally appropriate care?
That question is music to my ears. I'm very, Don Wasylenki talked about Brian Hodges starting that OPOP program a number of years ago. It might be almost 20 years now. And I feel very fortunate to work in that program, but I think that is part of the social shift that's happening. And there are so many things I could say about this, but one of the important things is working with people in local communities, people with lived experience, either as patients, caregivers, and also health providers to figure out what is the kind of care, what are the needs, and involve them in designing that care. And also working with regional partners. We used to be called in Thunder Bay the flyover service because we would fly over a big regional center in order to deliver care in these small places. So again, thinking about how we work with appropriate partners and contribute to the health system. I'm going to leave it there for now, but get in touch because I love talking about this and love to hear your ideas.
We have another question from Michaela Beater. Do you know if there are ways that we, as a profession, can advocate for access to internet and phones for people who don't have them? Some corporations have provided donations, but I wonder if there is a discussion about a broader strategy to provide access to our clients who are living in poverty and don't have internet or phones.
Yes, such a key question. And I think, people like you, Michaela, have gone out there probably and are like, I need a phone, I need 5 phones, I need internet. And I think we can take on that advocacy role to meet the immediate needs of our patients, but we also do have that kind of policy advocacy opportunity and responsibility where we can advocate for these system changes and for digital access as a right. It's a healthcare. If we're going to have public healthcare service and you can't access it because you don't have digital technologies, then it becomes an essential right. There is some work going on mapping internet connectivity across the province and then developing a strategy to get better connectivity, especially in smaller communities. But I think a lot of this work still is philanthropic and will need ongoing advocacy.
Wonderful. Thank you so much, Dr. Allison Crawford, for taking time out of your busy schedule to join us today and share with us your experience and expertise in virtual care and speaking to us about virtual design, exploring what learners and supervisors need to know to provide safe and equitable care. It was a very valuable presentation and a stimulating discussion in the breakout sessions and even now during our question and answer period. So thank you so much. We are now going to close the plenary and we will have a break now for you to stretch your legs, grab a coffee. We'll have 10 minutes and then we'll return back to the same link for our poster showcase.